A very good morning to all. On behalf of the Indian Society of Pediatrics and Preventive Dentistry and the KLE Society's Institute of Dental Sciences, Bengaluru, I, Dr. Kriti Nelamakada, welcome you all to today's program. In the journey towards becoming dedicated pediatric dentists, every postgraduate student has, is, and will be scrutinized for his or her competency through exams. For many of us, exams make the smallest hills feel like the biggest mountains. In an endeavor to enable the postgraduates to take these mountains in their stride, the ISPPD started their flagship program of a virtual rapid revision summit. On behalf of the ISPPD, we at the KLE Society's Institute of Dental Sciences, Bengaluru, are proud to be hosting the 6th edition of the virtual Pedia RaRe 2025. No event can be successful without the blessings of the divine. Let's start the program with a virtual lighting of the lamp. I now call upon Dr. Madhu K, Vice President, ISPPD, and our Head of the Department at KLE Society's Institute of Dental Sciences to introduce the program.
So very good morning to our Honorable President, Dr. Shashikiran Sir, General Secretary, Dr. Virendra Goyal Sir, and all the office bearers of ISPPD, distinguished speakers, moderators, and dear students. I sincerely thank ISPPD Head Office for giving us an opportunity to host ISPPD's flagship program, Pedia RaRe 6, a comprehensive rapid revision program for exam-going postgraduate students in the country. I extend my sincere thanks to our respected Dr. Rao Legde Sir for consenting to be the chief guest of the program. And I also thank our principal, who is a great support to us, for consenting to be the guest of honor for the program. And this comprehensive program is spread over 4 days in 8 sessions with 24 distinguished speakers and 16 moderators. And I urge the students to make most of this program, stay focused, attend all the sessions, and ask questions and clarify all your doubts. And wishing everyone the very best for your future coming exams. Thank you.
Thank you, Dr. Madhu. I would now like to invite Dr. Shashikiran ND, President, ISPPD, to kindly address our delegates.
Good morning, dear members. My dear mentor and my dear colleague, Dr. Rahul Sir, as a chief guest, and Dr. Srivatsa ji as the guest of honor, and my secretary, Dr. Virendra Goyal, and Dr. Madhu, Dr. Shivakumar Sir, Dr. Baby John, and the members of an ISPPD, and most of the students who are witnessing this Pedia RaRe 6th version of this ISPPD venture. A warm welcome to all of you. Just to say about Pedia RaRe, it's a 6th program or the 6th serial in this venture. We have around roughly 827 participants who have been registered along with us. and then there will be a 24 speakers along with 6 moderators. A warm welcome to all the people who are witnessing over here. Definitely, it will be a knowledge gaining experience for all the people of the students who are taking up the examinations, and also the students who are not taking up the exam. Maybe they are in second year or maybe they are in the first year also. They may be enlightened with our speakers. The speakers have done their maximum effort to give more of knowledge regarding an pedodontics or pediatric dentistry and the preventive dentistry. Hope this function will be a grand success. Before I concluding, I do acknowledge my sincere thanks to the efforts made by KLE Dental College, along with the principal, Dr. Srivatsava sir, and Dr. Madhu and his team. Thank you. Thank you very much.
Thank you, Dr. Shashikiran, for your encouraging words. I would like to call upon Dr. Varinder Goyal, Secretary General of ISPPD, to deliver the welcome speech.
Good morning. Thank you so much. And Honorable President Dr. Shashikiran, Chief Guest of the Day Dr. Rahul, Guest of Honor Dr. Srivastava, Dr. Madhu, Organizing Chairperson of this very prestigious program of ISPPD, dear speakers, dear attendees, first of all, I extend my warm welcome to all of you. And as a secretary, we have shared the email to all the attendees that they need to re-register at Zoom platform. If at all your friends have not received any mail, you can share your link to all your friends so that they can watch it live. Even this program is available live on my Facebook as well as the ISPPD group. You can watch it live. But we are trying to do all the things possible which will help you in attending this program online. So that's why I was little occupied at the back end, replying to emails and messages and calls. I'm sorry for that. And I'll continue that. And good luck and wish you all the best and happy learning. Thank you so much. And please, let's carry forward the program. Thank you.
Thank you, sir, for welcoming our delegates. I welcome the chief guest for today, Dr. Rahul Hegde, Executive Member of the Dental Council of India. Dr. Rahul Hegde requires no introduction in the field of dentistry. He is an academician par excellence and is responsible for regularizing dental education in the country. He has completed his Bachelor of Dental Surgery in 1992 from the prestigious KLE Society's Institute of Dental Sciences, Belgaum. His passion for learning did not stop even after he completed his MDS in 1996 and has obtained his PhD in the year 2010. He has been representing the Dental Council of India for more than 18 years. He has been elected as an executive member of the DCI for the 4th term, making him the longest serving executive member in the history of the DCI. Additionally, he has been a Senate member of Maharashtra University of Health Sciences as the longest serving member to the university for 11 years. Professor Rahul Hegde has 43 national, international publications and many patents and copyrights to his credit. He has been the co-chairman, Government Liaison Committee for the Federation Dentaire International in 2014. He has been a recipient of the Fellowship of the Royal College of Surgeons, England. He is the recipient of the prestigious T.C. White Award presented by the Royal College of Physicians and Surgeons, Glasgow. Presently, he is a board member of the Education Committee of the IAPD for his 2nd consecutive term. He is also a member on the Postgraduate Board of Studies of RGUHS Bengaluru and Punjab University, Chandigarh. He is the Vice President of the South Asian Association of Pediatric Dentistry. He is also a founder member of the Federation of Special Care Dentistry, and in collaboration with Special Olympics Bharat, he has set a Guinness World Record by screening 75,000 special athletes pan-India at 75 centers in 75 cities on the occasion of the 75th Independence Day. He is the president of BJP Dental Wing, and he is on the governing body as a member of Malvanchal University, Indore. His vision is to uplift the standards of healthcare in the society and community at large, at par with global standards. Now, I would like Dr. Rahul Hegde to kindly address the delegates.
Respected President of the ISPPD, Dr. N.D. Shashikiran sir, the Secretary General, Dr. Virender Goyal, the organizer of this rapid revision program, Dr. Madhu, the office bearers of the ISPPD, speakers, the senior faculty members, and my dear students. A very good morning to all of you. I would like to sincerely thank and congratulate the Indian Society of Pediatric and Preventive Dentistry, that's ISPPD, and the organizing committee headed by Dr. Madhu and his team for organizing such a thoughtful and much needed academic initiative. For an exam going student, I understand the pressure, the anxiety, and the sheer volume of the material that are expected to revise and recall in a limited time. In that context, this rapid revision program is nothing short of a blessing. This program not only helps them to revisit the key concepts in a structured way, but also gives them a sense of direction in their final stages of preparation. Such programs reflect the commitment of ISPPD to academic excellence and student welfare. We are truly fortunate to have such a national body that actively supports everyone and the budding students and the budding pediatric dentists through every stages of their academic journey. I extend heartfelt gratitude to all the organizers, speakers, and faculty who have contributed their time and knowledge for the benefit. Let all the students make the best of this opportunity and approach the exams with renewed confidence. Wishing all the fellow students and budding pediatric dentists the very best. Thank you, ISPPD. And thank you very much for giving me this opportunity part of this program. Thank you.
Thank you, sir, for your kind words. I now request Dev to share the certificate of appreciation.
Thank you very much.
Thank you, Dev. Our guest of honor for today is Dr. Srivatsa Ji, Principal of KLE Society's Institute of Dental Sciences, Bengaluru. Dr. Srivatsa has been the principal at KLE Society's Institute of Dental Sciences since 2012. He completed his Bachelor of Dental Surgery in 1992 and did his MBS in Prosthodontics from King George's Medical College, Lucknow, and having secured the 3rd rank in the All India PG entrance examination. He has been an academic council member for the RGUHS as well as Siddhartha University, chairman of the Postgraduate Board of Studies of RGUHS, and president of the Indian Prosthodontic Society, Bengaluru branch. Currently, he is a member of the Karnataka State Level Committee for drafting oral health policy, the Danta Bhagya Yojana. Thank you, sir, for gracing this occasion. I now request Dr. Srivatsa to address the delegates.
Thank you, Dr. Kriti. Good morning, everyone. President of ISPPD, Dr. Shashikiran, Secretary General, Dr. Virender Goyal, our chief guest for today, respected Dr. Rahul Hegde, Dr. Madhu, our staff members, and senior pedodontists of all over India, and my dear exam-going students. It's my proud privilege to be addressing the team of pedodontic students today. And I'm particularly happy that our Department of Pedodontics, led by Dr. Madhu, Dr. Srinivas, Dr. Ravi, Dr. Kriti, and Dr. Virender, are part of conducting this program for exam-going students. I have a lot of respect for pedodontics, and I always keep saying that if pedodontics make sure that all the children's teeth are looked after well and permanent teeth erupt well, then the other departments might have not much to do. So in this way, the pedodontics have a very great role to play in maintaining the oral health of the citizens, the patients. And I was going through the topics decided by the organizing committee. Each topic has been very carefully decided and very carefully crafted. And I'm sure that the exam going postgraduate students will benefit a lot from these topics. And I'm very thankful to all the resource persons and moderators for having agreed to be part of this program. And I'm sure that this program will be of great help to all the exam going students. And please make sure that you being a online or virtual webinar, it requires a lot of commitment from the students to make use of these such programs. And I'm sure that you understand that and make use of it. And once again, all the best to all the exam going students. And I would like to see many of you to be practicing exclusive pedodontics and making pedodontic specialty one of the very popular specialty in the country. And thank you for giving me opportunity. And thank you. And thank you to all the office bearers of ISPPD. And thank you one and all. Thank you.
Thank you, sir. I request Dev to share the certificate of appreciation. Thank you, Dev. And now, without further ado, let's begin with today's session. I request Dr. Srinivas LS to coordinate our sessions for the morning.
A very good morning to all the faculties and the dear postgraduate students. It has been a memorable journey for the past couple of years conducting various ISPPD programs with a team, KLE Society's Institute of Dental Sciences, Bengaluru, led by a dynamic leader, Dr. Madhu Sir. Thanks ISPPD for bestowing responsibility and trust in our team. So without further delay, we'll start the first session of Pedia RaRe 6. So before we start the session, I would like to request students that if they have any queries or questions regarding any of the ongoing topic, they're supposed to message in the chat box so that we can try to address their issues within the limited time, right? So we'll start the session today. We have three topics which will be covered by the three esteemed speakers, Dr. Sonali Saha, Dr. Ashwin Rao, and Dr. Sharath Asokan. So before we start the session, I would like to introduce the two moderators of the morning session, that is Dr. Baby John sir and Dr. Sudhindra Baliga sir. So Dr. Baby John sir is a specialist pediatric and preventive dentist serving as Dean at Vinayaka Missions, Shankaracharya Dental College, Salem. He completed his BDS and MDS from Bapuji Dental College and is the fourth generation dental professional coming from a family of dentists. He has served as a teacher, mentor, advisor, administrator, director, principal, and dean. He has published numerous researches in national and international peer reviews, journals, and patents in the specialty. A winner of various state and national awards, he has been awarded the Star Pedodontist Award by Indian Pediatric Dental Society. He has been graced with a fellowship of the Royal College of Physicians and Surgeons of Glasgow, and his acknowledgement of his expertise and dedication to the field of dentistry. The second moderator of the day is the dynamic Dr. Sudhindra Baliga sir, who is presently working as professor at Malabar Dental College and Research Center, Mallapuram, Kerala. He is a former dean at Sharath Pawar Dental College and Hospital. He graduated from A.B. Shetty Memorial Institute of Dental Sciences, Mangaluru, and in 1999, and Pedodontics from Yanapoya Dental College, Mangalore, in the year 2002. He has completed his PhD in the field of pedodontics, the focus of his research being on sickle cell anemia in tribal children. Fellow of the prestigious Royal College of Physicians and Surgeons of Glasgow. He has served as Associate Editor from 2012 to 2016 and Editor-in-Chief from 2017 to 21 of the Journal of Indian Society of Pediatrics, a PubMed indexed journal. President-elect of the prestigious ISPPD, he has published over 100 peer-reviewed scientific papers and research abstracts in the scientific dental literature, delivered guest lectures in several national and international conferences, and contributed as an author in specialty textbooks. Now I request Dr. Baby John, sir, to introduce the first speaker of the day, Dr. Sonali Saha. Over to you, sir.
Yeah, thank you, Dr. Srinivas. Let me have the honor of introducing our first speaker for this session. Dr. Sonali Saha graduated her BDS from R. Ahmed Dental College and Hospital, Kolkata, and MDS from SPPGIDMS, Lucknow. She has also completed her PhD, as well as she's now holding the post as a professor and director of and PG Guide, Department of Pediatric and Preventive Dentistry, SPPGIDMS, Lucknow. She has published various publications at the national and international forum, as well as in the journals. She was a good speaker, and she was awarded various accolades for her achievements. Few of them are gold medal in oral and dental anatomy during her undergraduate sessions, and she is a recipient of ICT Merit Award. She has also won the Best Paper Award in 36th, 38th, and 39th ISPPD conferences. She has been awarded the Outstanding Researcher in Pediatrics by the Synodent International Award 21, and also awarded as a Pediodontist of the Year by the Asia Pacific Dental Excellence in 2022. She's got various other accolades. So today we have Dr. Sonali Saha, who is going to brief on behavioral guidance, specifically basic behavior guidance for the morning session. I welcome Dr. Sonali for this session. Thank you so much.
A very good morning, and thank you, Baby John sir, for the introduction. And first, greetings from myself to respected Dr. Rahul Hegde sir, our President sir, Dr. Shashi Kiran sir, Virender Goyal sir, our lovable secretary, all the moderators, all the speakers here, all my colleagues, respected Madhu sir and his whole team. I thank you for giving me this invitation, and over and all, I thank ISPPD for bringing me here for whatever I am. And I'm starting my session today and on basic behavior guidance. Thank you so much, sir.
A very good morning to respected chairpersons. Myself, Dr. Sonali Saha. I'm here today to start the virtual Pedia RaRe session, 6th edition, organized by Indian Society of Pediatrics and Preventive Dentistry in collaboration with KLE Institute, Bangalore. Today, my topic allotted is basic behavior guidance. And I will be covering this topic under two broad headings as communication and communicative guidance and the advanced behavior guidance. These are the contents of my presentation today. As perfectly stated by McAlery, although operative dentistry may be perfect, but the appointment is a failure if the child departs in tears. And as pediatric dentists, we should always be trained to read the child's mind. The main aim of pediatric dentistry is always to create a positive attitude in the children following a dental visit by the impressions created in the child's first dental visit. As we all know that the first dental visit is always associated with anxiety and fear in the child, as the anxious child always perceives the dentist as a threat.
Dr. Sonali, can I
Act
intervene here?
1975 has defined behavior management
Sound echo.
as the means by which the dental health team effectively and efficiently performs dental treatment, thereby instilling a positive dental attitude. But according to AAPD 2024 guidelines, it has been modified as behavior guidance. And behavior guidance is defined as a continuum of interaction involving firstly the dental team, the patient, and the parent directed towards communication and education before and during the delivery of care. Now, the main goals of behavior guidance happens to be alleviating the fear and anxiety, promoting child's positive attitude towards oral health care, establishing a proper communication, promoting patients and parents' awareness, providing quality oral health care, and first and lastly, building a trusting relationship. Now, behavior guidance techniques, they range from establishing or maintaining communication to stopping any unwanted, inappropriate behavior. Behavior guidance should never be aimed towards punishment, power assertion, hurting, or shaming the child. Hence, we can talk as communication being the key to success. Communication happens to be a complex, multisensory process, having the ability to listen, empathize, ultimately establish a trusting dentist-patient relationship. Consequently, behavior guidance is as much an art as it is a science. So the biggest challenge that we face as pediatric dentists is maintaining a communication with a child. Lab in 1993 reported that 25% of patients are lost due to poor dentist-patient communication over a period of 5 years. And communication is always a two process with verbal utterances and non-verbal cues. Mehrabian in 1972 rightly stated that 55% of our communication is through non-verbal elements, like it can be facial expressions, it can be different gestures or postures, etc. Only 7% is in words, while 38% is in the vocal quality, in the tone, in the volume, and in the pacing. So, communication management and appropriate use of these commands, however, makes the child's exposure to the dentist very much acceptable and pleasant. There are three basic models describing the characteristics of verbal communication. First is activity-passivity, in which the dentist is in total control of the situation and he's always asking questions, and there is active listening on part of the dentist to establish a rapport and trust. Second is the guidance and cooperation, where the child allows the pediatric dentist to direct on the assumption that the dentist has all the knowledge and expertise required to help him or her. And thirdly, it is the bidirectional communication, where there is a two-way exchange of information between both the dentist and the patient, and both of them, they make decisions together. Now, which is the best to describe this conversation between the dentist and the child? We cannot say which is the best or which one to use. We always have to adapt and modify according to the office and the situation. So, hence, the child-centered approach comes into talk. It is the dentist's responsibility, however, which lies in alleviating the child's fears and gaining his or her trust and cooperation. The child-centered approach has three verbal approaches. First is a permissive approach, the empathic approach, and last is the personal approach. In the permissive approach, the patient is provided with all the relevant information required to reduce the fear and anxiety. Second is the empathic approach, in which is the capacity to accommodate in another's shoes, that is, the ability to feel the situation, to experience the situation, what the child is facing. And thirdly, it is the personal approach, whereby we establish a rapport with the child, we build a trustful relationship, and ultimately create a feeling of a safe environment. Now, the child-centered approach has been modified by Sharath Asokan and Nufulazar, and they have coined a new terminology as pediatric dentistries. And I'm very, very blessed to be associated with both the stalwarts of child psychology and behavior management. The proactive development based on the individualized communication between the pediatric dentist and the child, which helps to build trust, allay fear, and treat the child effectively and efficiently, happens to be the key words of the pediatric dentistries. And this message has to be conveyed differently to different age groups. Now, what is the communication? Just to brush up based on age. The first form of communication in newborns is cry. However, their speech is a child-directed speech. Infants, they communicate by different types of cries, gurgles, grunts, and there are a lot of non-verbal gestures like eye movements, bodily movements, facial expressions, etc. Infants, later between the age of 2 to 4 months, they start making sounds. And their communication is more of a pre-language communication. At 4 to 6 months of age, they start one-syllable sounds, and the moving then turns into different types of babbling. In the next few months, the babbling incorporates sounds, and they learn from the native language environment. By the first birthday, infants usually say their first words, but that is, they respond very quickly, and this language is called echolalia. They try to repeat the same sound. If you ask them, if you just tell them thank you, they just repeat why thank you, why thank you, why thank you. That's what they start repeating, what you and I say. Toddlers up to the age of 3 years, they have different types of gestures, and they start with 1 or 2 sentences. At 18 months, there is a vocabulary burst. At the second year, the words become different types of symbols, and later on, these words, they are combined into different types of phrases. All children, they use language in the same way. They try to give the basic information, and they like to explore and move around, and they are very much excited to see the new environment of the dental office. And hence, if there is a use of symbolic play, euphemisms, and non-verbal communication. Preschoolers, by the age of 3, they most begin to talk in full sentences. There can be correct words, there can be incorrect words, but all is present in the same sentence. By 6 years, there is grammatically correct sentences. And these children are more curious, more talkative, and verbally very enthusiastic. They start active listening with appropriate responses, and they have a lot of imaginative skills at this time. Role playing and modeling, however, they help in enhancing the communication with the child. By 6 to 12 years of age, these children, they feel very comfortable with a touch, with a handshake or a pat, and some of them, they use delaying techniques or tactics that during the dental procedures, please wait, please give me some time and all this. But they always want to be treated like big kids, and hence they should be allowed to express their fears and emotions. But adolescents, yes, we have to, it is such an age that they always act more negative and they have conflict with adults. They are neither a child nor an adult. So we have to seek or understand their perspective first. And eye contact should never be forced on them. There, however, identity and peer relationships are the key issues during this adolescent stage, and communication through touch only should be done when it is welcomed by them. Their reactions, however, can be under-exaggerated or over-exaggerated too. Yes, parents and pediatric dentists, we have to cater to them too, and communication with the parents is an added challenge to us, because parents think that their child is the most beautiful and the most smartest baby on earth. as patient. So communication and communicative guidance integration, it is an integration of specific techniques, however, leading to the evolution of a cooperative patient. And it is an ongoing subjective process. It is not that you use one technique and it's done. It is just using one after the other and just checking out which works better than what. So communicative basic guidance, it does not require any specific consent. All other behavior guidance techniques, however, require informed consent, which we should be consistent with AAPD's informed consent and applicable state laws. A signature, however, on the consent form does not necessarily constitute an informed consent, because informed consent implies to all the information related to the parent, the risks, the benefits, and the alternatives that are discussed, the questions that are answered, and permission then it is obtained prior to the administration of treatment. Now, if the parent refuses to give consent, then we have to gather the informed refusal form, and that has to be signed by the parent and retained in our record. So associated with this process are different specific techniques. First happens to be the pre-appointment behavior modification. It can be a pre-visit imagery, where we are just giving him some images before the dental appointment and asking relevant questions before the procedure starts, whether he or she has any problem, or problem means any type of fear, any anxiety, which we can cater as before the treatment is starting. Next is teledentistry, which facilitates better patient management, and it is a supplement to face-to-face method. Next is direct observation. Here, we ask the child to directly observe a cooperative child, or we show a video so that the child gets familiarized with the dental settings, and it provides an opportunity for the parent to even ask necessary questions. Next is multi-sensory communication, where comes tell, show, do technique. As we all know, it is one of the cornerstones of behavior management, where we are communicating with the child, favorably conditioning the child, and then attempting to remove the unknown fear or stimulus. However, there are different types of modifications of the tell, show, do technique. One is the tell, play, do, the tell, show, play, do, tell, read, do, the dental dictionary, draw, tell, conversations, ask, tell, ask, as included by AAPD in the 2024 guidelines, and the audio tactile performance technique. Now, tell, play, do, it was first instituted by Vishwakarma et al. In the year 2017, where it is an application of customized dental imitating, and it is more effective than live modeling as seen in different literature, and it has mainly acted on decreasing the child's anxiety among 5 to 7 years age group. The tell, show, play, do, it is a battery operated play-doh doctor drill and set toy introduced to familiarize them with the dental setting. It consists of the suction, the air rotor, the air water syringe. However, next is the tell, read, do. It was advocated by Anshula Deshpande et al. In 2019. It is a storybook where it is self-designed, which has different types of picture series, and a dental dictionary has also been created by her, designed based on substitute words using euphemisms, also called as the second language, and there are flashcards displayed for the visual and the auditory purpose. The draw-tell conversations, they initiate conversations, and then we ask the child to draw whatever he feels like or whatever he's thinking about, which increases the conversation. The AAPD has advocated the ask technique, where it is the main objective is to assess anxiety, teach the patient about the procedure, and then confirm the patient is comfortable with the treatment even before we are proceeding with the treatment. Yes, the feedback very important, because the dentist or the staff related ask the patient to teach back whatever he or she has learned. This pertains to explanations or it can be demonstration. The audio-tactile performance techniques is mainly for the visually impaired. Next we come to the voice control technique. The voice control technique, it is the deliberate alteration of the voice. It can be the tone, the volume, or the pace, but it is contraindicated in patients who are hearing impaired. And an explanation before its use may prevent any type of misunderstanding with the parent. Technique is, however, used where we want to gain attention of the child so that a proper communication is or can be achieved. It is very effective in children between 3 to 6 years, but used in children who exhibit a defiant and hysterical behavior. The technique timing should not be more than 20 to 30 seconds and contraindicated in children under the age of 3 years and those who are physically, mentally, or emotionally disabled. There are different types of variations of this technique: the hand-over mouth technique, the hand-over mouth and the nose and the airway restricted technique, the dry towel over mouth, the dry towel over nose and mouth, and the wet towel over nose and mouth. Next, we come to the non-verbal communication. It is through different types of postures, body languages, or facial expressions, crucial in toddlers and preschoolers. So the different types of facial expressions, it can be a smile, it can be a frown, it can be just waving the child, pointing to them, using different types of fingers, thumbs, or etc. And another important communication is use of the tone of the voice, the loudness, the touch, or the pitch, which is also called paralinguistics. The body language posture is also very important, and sometimes we pedodontists are left with only this resort. Next is the proxemics. What is proxemics? It is the study of the spatial distances between individuals, because each child may require a personal space. So because there is always a fear of intrusion, which is very important, and it is a dental fear in children. Eye contact is very important to make and maintain in a child, and sitting and speaking at the eye level, it shows a friendlier and less authoritative nature. This is communicating through touch. A handshake or a pat, it can be the use of good social reinforcers in the dental office. Now, positive reinforcement. Positive reinforcement, the main objective of this is strengthening the likelihood of recurrence of very good behavior. It can be social reinforcers like a voice modulation, it can be facial expressions, verbal praise, it can be also a descriptive praise rather than a normal generalized praise. Non-social reinforcers like tokens, toys can also help. Yes, distraction, it is just diverting the patient's attention. It can be audio, it can be visual, it can be different types of imaginations, it can be stories, it can be using of virtual reality classes, etc. Now, audio-visual distractions, the clown therapies, any type of distraction, a lot of studies have also been carried out and still being carried out. The virtual reality classes, the iRobi, which is the humanoid Robi that has been advocated by Yasmin et al. In 2016, is also a techno-psychological distraction technique. The appearance of the dental clinic also has a very good impression in different types of mood elevation. Use of child-friendly colors like yellow and blue in the dental office has been found to enhance a positive attitude in the child's mind. And the attire of the dental team, the hairstyle, the appearance of the dentist also influence the emotions of the child. Now, next coming to memory restructuring. Now, what is memory restructuring? It is the memories associated with any type of negative or difficult event. It can be a local extraction or the first dental visit. They are restructured into positive memories using all the information that has been given by the child after the event has taken place. This approach was received local anesthesia in the first dental visit, and they showed a change in local anesthesia-related fears and behaviors in the subsequent visits. Now, restructuring, it involves 4 components. First is visual reminders, positive reinforcement through verbalization, concrete examples to encode sensory details, and a sense of accomplishment. Now, a visual reminder, it can be any photograph of the child smiling at the initial visit. And then a positive reinforcement through verbalization, it can be just asking the child if the child has told his or her parents what a good job the child has done during the treatment or during the last appointment. And the child is then asked to role play and tell the dentist what she or he has told the parents. And ultimately, what the concrete examples to encode sensory details include, we should include praising the child ultimately, like if the child has kept her hands in the lap, or the child has kept the mouth open for a long time and allowed us to do. So the child is then asked to demonstrate all these behaviors, which leads to a sense of accomplishment. Reframing is nothing but, however, we take a situation outside the frame and we visualize it in a way which is acceptable. However, the dentist makes the child relax, and then the ability to reframe according to the level of understanding of the child. And reframing, however, will be a failure if the child is less than 3 years of age. Systematic desensitization, it is a psychological technique to modify an anxious child. Where do we indicate it? For patients who have experienced fear-invoking stimuli or anxiety or any type of neurodevelopmental disorders. So relaxation training is followed by gradual exposure to the fear stimuli. Patients may review the information regarding the dental office at home. It can be using a video, or it can be a book, or by viewing the website too. Now, there is, you should be very much clear about the differentiation between the two terms as systematic desensitization and flooding. Now, both are exposure therapies that help people face their fears. But in terms of flooding, a person is immediately exposed to the fear. But in systematic desensitization, the exposure to that fear is very much gradual. In flooding, the person is exposed to the most difficult stimuli right away. But however, in desensitization, the person starts with the least fear stimulus and gradually they go higher up. Flooding sessions are typically, it may be a long session, while systematic desensitization, they require multiple sessions because we start with the least fear stimulus first. Enhancing control, we always allow the child to play an active role. We may ask them to raise the hand. We may ask them for a thumbs up, which allows the patient some measure of control. Dental operating microscope has also been a behavior modification technique, and a study by Dimple Padave et al. Has shown that there is a reduction in anxiety from the first visit to the second visit while using the dental operating microscope. Now, coming to the communication techniques for the parents. Now, because parents are the legal guardians of the minors, so a bidirectional communication is very important. But there are some challenges for an open and clear communication because the socioeconomic status, the stress level, the varietal cord, or the dental attitude may be a barrier. So communication techniques like teach back, ask, tell, ask, or motivational interviewing can engage in a good patient-parent-centered approach. Now, some additional considerations for dental patients with anxiety or special healthcare needs is first the sensory adapted dental environment, also called as the SADE. It includes making the clinical setting a very calming environment. It can be the use of dim lighting, it can be the use of an aquarium or bubbles on the ceiling. In tactile sensations can be using a weighted vest. It can be a very soothing music being played, or the use of fluzelon has also been found to be very much helpful in modifying the fear and anxiety of the child. Next is the animal assisted therapy, and it is an adjunctive technique utilizing a trained animal to improve the interactions and to, however, decrease the patient's anxiety, pain, or emotional distress. And I had the opportunity to visit DY Patil, Pune, where Navi Mumbai, and there I found the head of the department, Dr. Shilpa Shetty ma'am, who has a whole cubicle or a whole area which is for animal assisted therapy in her institute. And either the child, if they have a pet at home, they are allowed to come with the pet, or pets also are hired and are brought for the decreasing the stress or anxiety of the child. Thank you, Shilpa Shetty ma'am, for giving me this opportunity, and thank you for giving me the consent for using this photograph too. The picture exchange communication system is also an adjunctive approach mainly used for children who have problems with verbal communication, or it is for individuals who have very limited communication abilities, and it is in the form of symbolic imaginaries. Next, we come to mind-body therapy. Now, the mind-body therapies in children include the biofeedback, the breathing exercises, and hypnosis. In biofeedback, we use electric or electromechanical processes. And in hypnosis, we are just steering the attention of the child to influence the cognition or the emotions to achieve the resultant behavior. Breathing exercises, it can be just deep inhalations, exhalations alone, or it can be used as a component of meditation. The main objective of these mind-body therapies are to replace all those negative thoughts with some positive attitudes, indicated mainly in children with situational anxiety. Guided imagery, where there is a directed, deliberate daydreaming, which has also been used, but I think a lot of studies need to be done in Indian scenario. And another which I would like to just add up here is the use of implosion therapy, which is repeated exposure to any type of anxiety-provoking stimuli in the form of a visual imagery. Hypnosis is also being used, which is nothing but hypnosis, which is a focused attention in response to an experience, however, either facilitated by a hypnotist or self-guided. Hypnodontics is defined here as the art and science of using hypnosis in dental practice, but it should usually last from 20 to 50 minutes. Advanced behavior guidance, as in the starting of the session, I told you, one part of basic behavior guidance was communicative guidance, and the next was advanced behavior guidance. Now, advanced behavior guidance has three main plots: protective stabilization, sedation, and general anesthesia. As we all know, there are different types of restraints, active, passive, and different types of mouth props, passive boards, towels, we are all accustomed to. Hence, multisensory communication, distraction, animal-assisted therapies, PET, SATE, desensitization, non-verbal communication. We have a bucket of these different behavior guidance techniques. So we have to be very much familiar as to which technique or multiple techniques which can be used for each patient. We have to modify and adapt according to the situation, according to the child. Hence, knowledge of these options will, however, help us in providing patient-specific, family-centered behavior guidance for infants, children and adolescents, and children with special healthcare needs. Hence, to end, keep caring, keep talking, and keep listening. A few questions which I have added that usually comes in the university papers. I'll share my presentation. You can just take a look. Some books to refer. Yes, and a small note for the PG students that a little progress each day adds up to big results. Hence, right from the start, if you start modifying and adapting different types of behavior guidance techniques, it will be definitely helpful for you all. I know your exam preparations is in top notch. All the best for your exam. I cannot end without gratitude to ISPPD, for which I am here today, who has given me this opportunity to stand be here before all of you. Thank you, Virender Goyal sir, Shashi Kiran sir, and all the office bearers for giving me this opportunity. All my TC members together, and my biggest thanks also to Dr. Madhu sir and the whole department, his team from KLE Society's Institute of Dental Sciences, Bengaluru, my family, and my extended family, all the faculty members of my department, and my backbone, my PG students. Thank you from the city of Nawab. Thank you all. I'm open for questions. If you want, you can just also ring me up and give me a call. Thank you.
Thank you, Dr. Sonali, for this wonderful lecture.
Thank you so much, sir. Thank you so much.
I don't see any questions here since you have said that they can write to your email. So probably they'll be writing it to you directly.
Yes, sir.
And I think can we just move on to the next session? Dr. Madhu has to decide about it, or shall we wait for Dr. Srinivas?
Sir, can I just take a few minutes, sir?
Yeah.
Firstly, thanking the whole team of Madhu sir and his whole team, because 2 times I had sent my presentation, but it was not uploaded. And I think so I troubled Madhu sir a lot. And thanking ISPPD, respected Goyal sir, respected Shashi Kiran sir, and all the office bearers of ISPPD for giving me this opportunity. And thanking you all, and requesting all the PG students, whoever has attended, if they have any queries, please let me know. I can share all the articles with you. And the main mantra, I think so, is following the AAPD guidelines, because it has everything and anything in it. I think so it is a very valuable tool, not only for basic behavior guidance or any behavior guidance. It is for all the categories. The recent 2024 AAPD guidelines will definitely help you all. And I did not mention in advanced behavior guidance, one was protective stabilization, and the other two was sedation and general anesthesia, because we have the next sessions on conscious sedation, sedation and anesthesia. So I did not include these two in my topic. So thank you one and all. Thank you so much for everything. Thank you.
Thank you, Dr. Sonali.
Thank you, ma'am, for your presentation. There are no queries. So I request Dr. Sonali Saha to please accept the certificate of appreciation. Mr. Dev, if you can please project the certificate.
Thank you so much, sir. Thank you. Thank you so
Congrats,
much.
Madam. Thanks a lot.
Thank
Thank
you
you.
so much. Thank you
So we'll be starting the second session. The speaker for the second session is Dr. Ashwin Rao, sir. And Dr. Sudhindra Baliga, our moderator, is going to introduce the speaker. So over to you.
Good morning to all of you. I think the slide has to get displayed. Dr. Virendra. Okay, it's my privilege to welcome my dear friend, Dr. Ashwin Rao, who is currently working as professor and head in the Department of Pediatric and Preventive Dentistry, MCOTS, Mangalore. He has done his post-graduation in the year 2005 from Mahe. He is awarded the Vidya Tandon Memorial Gold Medal for the best outgoing postgraduate student. He is won also the best teacher, which is constituted by Mahe for academic years 12, 13, 16, 17. He's co-authored a textbook called Contemporary Treatment Techniques in Pediatric Dentistry by Springer, co-authored Stainless Steel Crowns in Pediatric Dentistry by Springer, granted a patent for design the Pedodontic Syringe, co-authored the wonderful textbook Midazolam by Pediatric Dentistry by Springer, won the Guide and Dental Excellence Award for the most proactive junior academician, He's been a guest speaker mainly on pharmacological and non-pharmacological behavior guidance in pediatric dentistry at various dental forums. He's co-authored the chapter Nitrous Oxide, Oxygen, and Anxiolysis and Conscious Sedation in the 5th edition of textbook of Pediatric Dentistry by Nikhil Marwa. He has 52 scientific publications in Scopus Index journals. Well, over to you, Dr. Ashwin, for your lovely presentation. Thank you.
Thank you so much, Dr. Baliga. Always a pleasure to see the young and dashing Dr. Sudhindra Baliga. Thank you so much. And thank you so much to the entire team of ISPPD for this opportunity. Thank you so much, Dr. Madhu. And yeah, I'm ready to start my presentation. Thank you. Respected chairpersons, Dr. B.P. John and Dr. Sudhindra Baliga, and my dear colleagues, good morning everyone. At the outset, let me thank ISPPD and the organizing committee, especially Dr. Madhu, for this splendid opportunity. The exam going PGs, look at the stage of your course which would be popularly expressed as the business end of the course. Since you're exam going PGs, I'm sure you already have a sound background in pharmacological management. Hence, I'm not going to go into the nuts and bolts of pharmacological management. In cricketing terms, this phase of your course will be called as the slog overs. So in the slog overs, I don't want to give big references you won't be able to go through. So this presentation will be an exam-oriented presentation, and the intention of this presentation will be to ease your understanding of the topic so that you can go and do well in the exams. So I'm going to deal with pharmacology techniques and behavior guidance under these 4 subtopics: minimal sedation, moderate sedation, deep sedation, and general anesthesia. So the flow of the presentation is going to be like this. Initially, I'm going to discuss the basics of each subtopic for you. And then I'm going to put up questions which have come from previous exams on this particular subtopic. Then we are going to construct answers to these questions. And finally, I'm going to give you specific references for that particular question, which you can go back and read. Now, coming to the basics of minimal sedation, all of you are, I'm sure, familiar with this definition of minimal sedation given in the classic article by Ford and Wilson. But what is more important than the definition is what amounts to clinical minimal sedation. Well, according to this, again, very important article by the American Society of Anesthesiologists, clinical minimal sedation means less than 50% nitrous oxide in oxygen with no other sedative or analgesic medications by any. It could also be a single oral sedative or analgesic medication administered in doses appropriate for unsupervised treatment of insomnia, anxiety, or pain. But in the context of pediatric dentistry, the second indication does not hold good because in pediatric dentistry, even a single oral sedative like, let's say, oral midazolam will not only lead to anxiolysis, but it may also make the child drowsy, automatically pushing him into the category of moderate sedation. So these 2 indications hold good only for adults. In pediatric dentistry, clinical minimal sedation means nitrous oxide used in concentrations less than 50%. So coming to nitrous oxide oxygen or inhalation sedation, from an exam point of view, it is very surprising that very few questions have been asked on inhalation sedation in the MDS exams. In fact, I went through the last 10 years of the Mahi papers, and only last year a question on inhalation sedation in 2024 has been asked for 100 marks. But students, this is going to change now because inhalation sedation has come of age in India, and inhalation sedation is the norm in pediatric dental practice today in India. So you can expect a lot more questions on inhalation sedation in the future. In fact, in the exams coming up itself, you can expect a lot of questions on inhalation sedation. So there are many textbooks which cater information on nitrous oxide in pediatric dentistry for you to read up on. But just before the exams, if you want a very good resource which will give you concise information on nitrous oxide in pediatric dental patients, then this is a very good reference found in the AAPD reference manual. This, in brief, describes the mechanism of nitrous oxide, case selection, technique, and monitoring, and is a very, very good read. But like I told you, more questions on nitrous oxide could be expected in the upcoming exam and in the future exams. So if something more specific on this topic, like scavenging, is asked in the exam, then you can go through this particular resource again in the same AAPD reference manual document on the policy of minimizing occupational health hazards associated with nitrous oxide, which is again a very good read. So now coming to moderate sedation. Now again, I think the exams are still not warmed up to this term moderate sedation. The popular terminology is still conscious sedation. Now, I think nitrous oxide oxygen sedation was not ignored in the exams, but it used to be equated to conscious sedation, which is not the case. And in the light of present knowledge, now we know that conscious sedation is equal to moderate sedation. And the evidence to this effect has been clearly provided again in the Court and Wilson document, where they clearly mention that conscious sedation is the old terminology and the currently accepted terminology is moderate sedation. But if you look for the term conscious sedation, you will find out that it's been asked numerous times in the exam. It's been asked as a short answer. It's been asked as a long answer. In fact, it's also been asked as a 100-mark question. So now, if a question on conscious sedation is asked, you should consider the question as moderate sedation and then answer appropriately. So the side headings you should include under this particular answer is, first you have to define moderate sedation, which is given in the Court and Wilson document. Then you should talk about routes of administration. Then you should talk about the drugs used in moderate sedation. And finally, you can talk about specific guidelines for moderate sedation. Coming to the routes of administration, let's simplify it. There are only 3 routes for moderate sedation. The first one is the enteral route, which consists of the oral or the rectal route. And then you have the parenteral route, which bypasses the first pass metabolism. This will include intramuscular, subcutaneous, submucosal, intranasal, or intravenous. And finally, we have the inhalational route, where we use nitrous oxide in concentrations more than 50%. Coming to the drugs, again, there are only 4 subcategories of drugs. The first one is sedative hypnotics, which include chloral hydrate, triclophos, and barbiturates. Then you have the anti-anxiety agent, which will include all the benzodiazepines, hydroxyzine, diphenhydramine. And then you have narcotics like meperidine. And again, you have nitrous oxide and oxygen in concentrations more than 50%. For the specific guidelines to moderate sedation, you can again refer this quote and Wilson document, which elaborates on this very nice. One of my favorite resources on sedation is this book edited by Arthur Jane Noah and other co-editors, which we popularly know as PinCam. Here you go to chapter number 8, Pain Reaction Control, Sedation. This is a very, very good resource to understand sedation in general, be it minimal, be it moderate, or be it deep sedation. So this is a very, very simple resource which will help you understand the concept of sedation. Now, one of the challenges of writing a theory exam is that questions are often picked up from the subtopics. So unless you have understood your basics and concepts really well, or unless you have pre-prepared for this particular question, it becomes very difficult for you to construct the answer within your stipulated theory exam time. So for example, let's take a look at this question, this short answer, conscious sedation with benzodiazepines, which has been asked in one of the previous papers. Now, if you want to answer this question, how you have to construct it is, you have to first talk about the advantages of benzodiazepines. Then you have to talk about the mechanism of action of benzodiazepines. And then you can talk about some commonly used benzodiazepines in pediatric dentistry, like midazolam, diazepam, or triazolam. So a very good resource for you to answer this particular question is the textbook of behavior management in dentistry for children, the second edition by Gerald Z. Wright. You can go to the chapter by Steve Wilson on minimal and moderate sedations, and this chapter will help you answer this particular question. Now, midazolam has been asked quite a few times as a short answer. So if a question like this comes, this is the way to construct the answer. First, you have to talk about the chemistry of midazolam, pharmacokinetics, pharmacodynamics and the mechanism of action, the routes of administration, advantages and complications. Now, a very simple resource for this particular question is this article by Kupitsky on a review of midazolam. It's a very, very simple resource on midazolam. So midazolam has also been asked as a 50-mark question. So if it's a more extensive question, then you can go to this more extensive resource, which is a textbook on midazolam in pediatric. You can use the same side headings that we have used for the last question. And you can go to these particular chapters, that is chapters Understanding Midazolam, chapter 5, Routes of Midazolam Administration, and chapter 8, which is called as Safe Sedation Attitudes to Forestall Emergencies. But sometimes questions in the theory exam could also be very simple. For example, this particular question, advantages and disadvantages of oral sedative route in pediatric dentistry, asked in June 2021. This is a pretty straightforward question, and I'm sure all of you know the advantages of oral sedation, which is also listed out here in blue, and all of you also know the disadvantages of oral sedation listed here in orange. A simple resource on oral sedation would be the textbook of sedation, the 6th edition by Stanley Melamed. Here you can go to chapter number 7 on oral sedation, which is a very comprehensive yet simple reference to understand oral sedation. So now coming to the basics of deep sedation and general anesthesia. Deep sedation and general anesthesia are a continuum. Clinically, the difference is only academic. In deep sedation, the anesthetic practically works in Google stage 1 of anesthesia or the ultralight plane of general anesthesia. In deep sedation, the child is practically unconscious unless a deeply painful stimulus occurs, and the only differentiating factor in general anesthesia is that general anesthesia is a state where the child is continually unconscious and unresponsive to any degree of painful stimuli. The common misconception is that IV sedation is equal to deep sedation, which is not the case. Deep sedation, or for that matter, general anesthesia, can be achieved with any sedative drug or any route. For example, chloral hydrate given orally in sufficiently high doses can lead to deep sedation or general anesthesia. IV route is the preferred route for deep sedation because the anesthetist can use specific IV drugs like propofol or fentanyl, which bring in deep sedation in small doses, ensuring quick and safe recovery. Now, what this last point means is that if your intended level of sedation is deep sedation, then it is better to achieve it through the IV route because here the anesthetist can use specific deep sedation drugs like propofol or fentanyl, which can bring in deep sedation in small doses instead of using moderate sedation drugs like midazolam or pedicloryl for deep sedation, for which you have to use these moderate sedation drugs in very high dosages, which will again bring in additional complications. Continuing on the basics of deep sedation and general anesthesia, another common misconception is that general anesthesia involves the use of gases and intubation, whereas the intravenous administration of drugs without the use of intubation is sedation. You should be aware of the technique acronym TIVA, that is total intravenous anesthesia, where general anesthesia is completely induced and maintained intravenously, either with intubation or with an open airway, basically where there is no intubation, depending on the extent of the treatment needs. Now, this is very important for you to understand because there have been several instances of intravenous drugs being administered inside the clinic, and the pediatric dentist assumes it to be treatment done under sedation. You should understand that that is not the case, and whether it is deep sedation or general anesthesia, it depends on the level of consciousness of the child, and it does not depend on the route which the preferred route or the drugs which were administered. This is a very, very important concept that you should understand. Now, for you to understand the concept of deep sedation and general anesthesia, I will give you three simple resources. The first one is the textbook of oral sedation for dental procedures in children. Here you go to chapter number 10, which is deep sedation and general anesthesia. And this chapter explains the concept very, very well. The second resource is the textbook of behavior management in dentistry for children, the second edition. Here you go to the chapter titled Working with a Dentist Anesthesiologist, page numbers 177 to 184. And this is again a very, very good chapter to enhance your understanding on the concept of deep sedation and general anesthesia. So the third reference I will suggest is the textbook of sedation, but please note, this is the 5th edition of the textbook of sedation by Stanley Melamed, not the 6th edition, it is the 5th edition. So in this textbook, go to chapter number 30, Fundamentals of General Anesthesia, and chapter number 31, Armamentarium, Drugs and Techniques. So if you read these three resources, then your concept on deep sedation and general anesthesia in pediatric dentistry will be very clear. So now, armed with sound fundamentals of deep sedation and general anesthesia, let us look at a few questions that have been asked on this particular topic in the previous exams. So one of the questions I came across is enumerate and describe drugs used in sedation and GA. Now see, this is again a very tricky question, and for you to be able to construct an answer to this particular question at short notice can be very challenging. So how you need to answer this question is, first, you can talk about the moderate sedation drugs, which we have already discussed, and I've already given you the reference for that. And then you can talk about the deep sedation drugs, that is ketamine, propofol, fentanyl, or analogs like remifentanil. And the details of these drugs you'll get in the last three references that I've given you. Coming to the second part of the question, drugs used in general anesthesia. Again, the three references that I've given you will give you information on the drugs used in general anesthesia. But a popular protocol used in general anesthesia is that first pre-medication is done with oral midazolam, then induction is done with propofol, ketamine, fentanyl, or other analogs. Succinylcholine is given to facilitate intubation, and then sevoflurane or IV meperidine is used to maintain anesthesia. A very popular question in the older question papers used to be ketamine. So to answer this question on ketamine, I'll give you two references. One is the chapter Intramuscular Sedation in the textbook of sedation by Malamud in the 5th edition. And then you can refer chapter number 25, that is pharmacology, again in the same textbook, which gives you sufficient information on ketamine. Another challenging question I came across on this subject is differentiate conscious sedation, deep sedation, and general anesthesia. Indications, contraindications in pediatric patient undergoing dental treatment. This was asked as a long answer. So how you construct this? You talk about the definitions of conscious sedation, deep sedation, and general anesthesia, and then you differentiate between moderate sedation and clump deep sedation and general anesthesia together, and then differentiate them. So the resource for this is again the Court and Wilson document, where you can go to table number 2, that is given in page 34E. There it differentiates moderate sedation and deep sedation very nicely. Coming to the second part of the question, give their indications and contraindications in pediatric patient undergoing dental treatment. Well, I have put up this table for you. This table, I have shared the indications based on my understanding. So I decide on the depth of sedation based on the Frankel behavior rating of the child. So behavior is positive or negative, I prefer moderate sedation. Deep sedation, I would go for a child displaying Frankel definitely negative behavior, where the concept treatment is limited to extremely short dental procedures. Okay, so I would use deep sedation and open airway, and when I say extremely short dental procedures, I mean maybe extraction of a first permanent extraction of molars, or maybe a pulpotomy and a hall crown with the judicious of the aorta along with the rubber dam. Okay, those I would consider as extremely short dental procedures. And where would I use general anesthesia with intubation? I would always do it in the operation theater, and I would use it on children displaying Frankel definitely negative behavior, where the child has extensive dental treatment needs. But to be honest, even deep sedation with an open airway, I would not do on the chair side. I would prefer to do any form of deep sedation or general anesthesia, always in the operation theater in the presence of an anesthetist. I would do only minimal and moderate sedation chair side on my own. For a more formal reference to this particular question, you can go through this reference, Behavior Guidance for the Pediatric Dental Patient, page number 261, 262 in Pediatric Dentistry 2018. Now let's take on the fourth question. It says, define sedation. Discuss the goals of sedation as defined by AAPD guidelines. Name the emergency drugs that may be needed to rescue a sedated child patient. It's been asked as a long answer. See, so questions are picked up from so many various areas of sedation, and it's very difficult to answer this in the theory exam. So the references to answer this particular question for goals of sedation, you can go through the behavior evidence, this one reference. And for the emergency drugs, you can go again through the Court and Wilson reference. You can also refer the chapter Emergency Drugs and Equipment, chapter number 33 in the textbook of sedation by Melamed, the 5th edition. All right, and the first part of the question, define sedation, that's pretty straightforward. Now all of you from the Court and Wilson reference will easily be able to answer the definitions on sedation. The first question is a simple full toss which you can come down the wicket and hit for a 6. Very simple, straightforward question. ASA classification system for general anesthesia, which has been asked as a short answer. So you can again go back to the Court and Wilson reference, and there you can go to page 51E, Appendix 2, and which explains this particular answer very clearly and very simply. The sixth question, pre-medication in pediatric dentistry, which has been asked as a short answer. It's also been asked as the role of pre-medication in pediatric patients, again as a short answer. Now, this can be a little tricky because there are many aspects to pre-medication. It can be used as anxiolysis before a dental procedure for good night's sleep. It can also be used to sedate the patient before GA induction. It can be used for its anterograde amnesia properties. Pre-medication can also be used to prevent post-operative vomiting. It can also be used for preemptive analgesia, or it can be used to facilitate the exception of the nasal hood in Frankel negative children or children displaying Frankel negative behavior. So a good resource to this particular question is you can go through this particular chapter, Pharmacological Behavior Management, in the textbook Pediatric Dentistry Principles and Practice by Dr. M.S. Muthu and Dr. Siv Kumar, page number 123. Question number 7, Pharmacological Management of Patient Behavior, asked for 100 marks. This is again a very simple question for you to answer based on everything that we have discussed, right from minimal sedation, moderate sedation, deep sedation, and general anesthesia. So this should be a very straightforward question for you to answer. And then the last question, I came across a question called conscious sedation versus general sedation in pediatric dentistry. Now, this is what you call as a bouncer, because we all know what conscious sedation is, but what is general sedation? There's no terminology called as general sedation. So probably this question has not been framed properly. So I think what the examiner was trying to ask is conscious sedation versus deep sedation in pediatric dentistry. And now based on all the knowledge of deep sedation and general anesthesia, I'm sure you'll be able to answer this particular question. So those were pretty much the questions that I came across in pharmacological management. And before I wrap up my presentation, let me just give you a few exam tips for the theory paper. Let me draw the analogy with a cooking competition. A theory exam could be like a cooking competition. In a cooking competition, if you prepare a dish which is delicious, but which is presented very badly and which looks very ugly, then what will happen? Then you'll end up with a very irritated judge who may not even taste that particular dish. A similar thing can happen with your theory paper, where you can answer a question and you can give a lot of information on that particular question. But if you rush and you expect the examiner to correct that particular answer written so shabbily, you will just end up with a very irritated examiner who will just give you maybe very basic marks to that question. So some good exam tips for your theory paper are: one, always structure the answer if possible. Put in side headings wherever possible. Underline important points and highlight it to the examiner. This draw margins. This has been taught to us in elementary school because it looks the overall page looks very neat when you draw a vertical and a horizontal margin on your exam paper. Write legibly. Please write legibly. It's very, very important. Draw diagrams, schematic diagrams, but draw schematic only where necessary. For example, if there's a question on the scavenging nasal hood, then maybe you can draw a schematic diagram to explain the flow of gases scavenging nasal hood. So that could be a very good schematic diagram. But if there is a question on different types of pipe, then don't draw diagrams. These schematic diagrams could look funny, completely unnecessary. So as you approach your exams, you are bound to have your good, but you may also have your gloomy days. So here is wishing all the exam going PGs that you have lots and lots of good days and very few gloomy days. And I hope I see you on the other end of the tunnel as the graduating batch of 2025, pediatric dentist, the graduating batch of 2025. Dear students, wishing you all the best for the upcoming exams. Well, I hope the last 32 minutes have been worthwhile your time. Thank you so much.
That's all from my end, sir. So, if there are any
Baliga is
questions,
around. Thank you, Dr. Ashwin. Good
Pleasure,
deliberation. Dr. Baliga, I think you have covered the topic with the specifics also, where to go, how to search, how to write. You have really done a wonderful job for the postgrads. It was really nice presentations, and I'm sure that the postgrads would have understood it, and you made it very simple where to look also. So since Baliga is not there, I think there's no questions over here. So I believe that people will be writing their queries to Dr. Madhu, or else if anybody wants, can also raise it.
I'll put up my email ID in the chat box, sir. So PGs,
right.
please feel
So-
free to ask any questions there also.
That's nice. Okay, then I think then that's it. Dr. Madhu, thank you so much, Dr. Ashwin. Good
Thank you.
deliberation.
Thank
Good.
you so much.
Thank you, Dr. Ashwin Rao, sir. I request Mr. Dev to put the certificate of appreciation to Dr. Ashwin Rao. Thank you. Thank you, sir. Now I call upon the next speaker, Dr. Sharath Asokan, and I request Dr. Baby John to please introduce the next speaker.
Thank you, Dr. Srinivas. It's my pleasure to introduce Professor Dr. Sharath Asokan, a good friend of mine, and who is currently the principal of KSR Dental College at Tiruchangod in Tamil Nadu. He was the youngest and the third pediatric dentist from India to have secured his PhD in our specialty. He was awarded the Young Pediodontist Research Award. I don't think he needs an real introduction because he's editor-in-chief of our renowned journal, ISPPD. Although I have to mention certain awards what he have received. That is a Health Excellence Award for the year 2009 by the Indian Board of Alternate Medicine. He received a Young Dentist Award from the Chancellor of Tamil Nadu, Dr. MGR Medical University, His Excellency, the Government of Tamil Nadu, Governor Dr. Rosia, as well as Dr. Sharath has won the Sam Harris Travel Bursary Award in the 29th International Association of Pediatric Dentistry at IAPD Congress in Maastricht, Netherlands. So Dr. Sharath is also an active member in preparing the students for their higher education, the NEET coaching. He has got an academy, ADE, as well as a very enthusiastic academician, I would say, and he's got a passion for psychology and child management. So I'm sure all of you know about it, and let's hear from that, and I'm sure that he will deliberate wonderfully to give some insight to the postgrads for the preparation. Thank you so much, Dr. Sharath. The platform is yours. Please go ahead. Dr. Srinivas, Dr. Sharath.
Mr. Dev, if you can please project Dr. Sharath Asokan sir's PPT.
Psychology for the postgraduate student.
Yes, Dr. Sharath, go ahead.
Very good morning to one and all present here. At the outset, I would like to thank ISPPD, the President, Secretary, for giving me an opportunity to be a part of this rapid revision program for the 6th time. A special thanks to Madhu sir and his team from KLE Bangalore for giving me an opportunity to share some of my experience and knowledge on the implications of child psychology for the postgraduate students. So I hope my slide is changing, and this is the title given to me today, Clinical Implications of Theories of Child Psychology. As you can see, this is a 40-minute session, and we have about 6 theories quickly to be seen. So I'm going to try and tell you how to answer a question paper if the question is asked in exam. So any question which is asked in psychology and it's asking you the implications of child psychology, I think you should start with the definition of psychology, that it's a scientific study of behavior and mental process. Behavior is anything which you can see, which you can observe, record it, and then measure. If somebody is sleeping, if somebody is laughing, somebody is smiling, somebody is crying, it is an activity which you can see, measure, and record. That is behavior. The mental process is something which you cannot see, which you cannot record because it's something which is invisible, and it's something like the thoughts, the memories, the emotions. So psychology is a scientific study of both the behavior and the mental process. And child psychology is part of this developmental psychology. People change from birth through lifetime. And child psychology is the study of children's behavior which includes the changes in physical, cognitive, motor, linguistic, perceptual, social, and emotional characteristics. And this changes continuously from birth till adolescence, and it still goes on. And this part of child psychology, this study which we deal with birth through adolescence is called child psychology, and it's part of development psychology. So any question which is asked in related to child psychology, I think you should start with this particular presentation. But I want you to understand that the theories, like what we read, is not actually how psychology is divided. Psychology is divided into 5 main perspectives or 5 approaches in psychology, which includes the biological first, and then there is psychodynamic, then there is behavioral, cognitive, and humanistic. And to simplify these approaches, we have different theories of child psychology. So I will be sharing this presentation with you so you can read about these perspectives for your reference and notes. So then we look at it as emotional development. Emotional development, give me a second. So emotional development will include psychoanalytical theory or psychosexual theory with Sigmund Freud. Any question asked on emotional development, you have to write about Sigmund Freud and Erikson. If it is about cognitive theory, then we write about cognitive development, which is given by Jean Piaget. If it's about learning, if it is about development of behavior. So this question can be learning separately or development of behavior. Then you write about the conditioning theories, classical conditioning, operant conditioning, and observational learning theory. So these are the 6 theories, but then we find that it is based on 5 psychological perspectives. Based on development, we are divided into emotional development, cognitive development, and development of behavior. Right. So let me come back to the basics. So let us say a child walks into a dental clinic and there is a question saying that it's a 4-year-old child. How will you behavior manage this child using certain psychological principles? So first thing, whether it's a behavior management question or child psychology, I want you to understand it goes hand in hand. And the first thing you should do in clinics or for a theory paper, I should say, you should decide which age group the child falls into. The child is an infant, toddler, preschooler, middle year child, adolescent, based on this Stone and Church classification. Once you have decided that the child fits into a 2-year-old, which could be a combination of toddler to preschooler, or the question is asked at 4 years, then you think it's a preschooler child. So what are the characteristic features of a preschooler child we need to understand? That we will learn in theories of child psychology. Then based on the principles of child psychology in a 4-year-old, we will have to look at the behavior management. So I think implication of child psychology will start into categorizing children, and that I think you should start with Stone and Church classification. So I'm just giving a small gist of certain characteristic features of certain children. So I started with this preschool children, less than 3 years of age, right? They have the fear of falling. They have fear of sudden movement. So moving the dental chair, the noise, the fear of strangers. We have to understand that the pediatric dentist is also a stranger. We cannot separate the mother from the child in the dental office. We cannot tell the parent to wait outside. So these are basic implications which we need to understand based on the characteristics of these children. So a 4-year-old child has fear of bodily injury. These children have been going to a pediatric dentist or pediatrician for quite some time, especially a pediatrician and a doctor, right from birth, and they've been having vaccinations. So fear of bodily injury, a prick into a mouth is very scary for children, right? Prick into a hand could be something which they have done in vaccination. A prick into a mouth could be very scary for them. So a drill or a fear of bodily injury is very common. A 5-year-old to a 6-year-old, they like to talk about their possession. They're going to school, they have new friends now. They like to talk about their possession. So if you want to establish communication, you can think about the bindi they're wearing, the dress they're wearing, or something like that. But why I want to tell you that look at the age and look at the characteristic features is, if you're looking at a 4-year-old child, so I want you to think, according to cognitive theory, where's the child? According to Jean Piaget, the child is here. Yes. Now, according to Sigmund Freud, where is the child? What is the characteristic feature of a 4-year-old child according to Erikson? If you can understand that based on the age, the characteristics of that particular age, and then look at application of these principles of psychology in behavior management, that is how the paper should continue, right? So this is the basic gist I'm giving you. The second thing about after age, I want you to write about after the age. The second thing they might tell you, the 4-year-old child is throwing temper tantrums. Very uncooperative child. If the question paper is asking questions like that, then you have to decide whether the child is 4-year-old, definitely negative. A very highly cooperative 3-year-old child. Then you say preschooler, type 3 Frankel, which is positive. So you have to decide after age, you will talk about Frankel's classification. And then you also decide whether the child is going to be under rights classification. Where is he going to fit according to rights cooperative behavior? I want you to really understand right considered all children to be cooperative. So he called the classification itself as rights classification of cooperative behavior, right? So if a child is cooperative, then you put him under cooperative behavior. If the child is lacking cooperative, the 4-year-old is making so much of noise, throwing temper tantrum, then it could be an uncontrolled behavior. It could be a defiant behavior. It could be a stubborn behavior, right? It could be a very shy behavior. So we will categorize the child based on Stone and Church. Then we look at the age of the patient according to that. Then we look at where the child will fit into Frankel and rights classification. So this is the basic background which we will do for a question paper, which is asking on implications of child psychology. If it is general question without any specific age group, then it's better. As a PG student, you mentioned that you will look at the age of the child. You look at which cooperative behavior the child will fall into according to right. Where will he fall into Frankel? And based on that, you will apply the principles of psychology, right? So as an adolescent, the same rights and esteem, actually almost after 39 years, 1975, they gave the first classification. 2014, they added another component called passive resistance. So adolescent children, okay, adolescents, they basically have passive resistance. They would not allow to establish eye contact. They will not look at you at all. They might not show resistance, but they will not look at you and speak, or they might answer very little bit, or they might just give you adequate information. This is called passive resistance. So it is important that you identify that age group has specific characteristics, and then we will proceed into the different theories of psychology, right? So as I told you, personality development, emotional development, we have to talk about psychosexual theory by Sigmund Freud and psychosocial theory by Erikson. Sometimes you have a question, psychosexual versus psychosocial. I will also give you an answer to that particular question at the end of this presentation. So you will also see that psychosexual theory, it starts with id, ego, superego, right? I want you to understand Sigmund Freud never treated children. He was basically a hypnotist and he treated adults. And these adults were successful lawyers who had depressions, right? Very powerful people who were very successful in life, but they were having depression. So he did psychoanalysis on these people and he analyzed that. He found out actually that during their early childhood, less than 5 years of age, they had some kind of trauma, which could be basically an aggressive conflict or a sexual conflict. These two conflicts, either aggression or sexual conflict, has affected their personality at a later age of time. So basically, he didn't treat children. He treated adults who were successful but having some personality disorders. And then he related that this could be because of the trauma which they had during their early childhood. So then they decided that the personality itself is an iceberg phenomenon because it has id, ego, and superego. The id works on a pleasure pain principle. Ego works on a reality principle, and the superego has two parts, which is ego, ideal, and conscience. Explaining id, ego, and superego in this presentation might not be really useful because we're looking at clinical implications, but then I want you to relate it when I come to this particular slide. Each Sigmund Freud and Erikson, I'm going to try and do it together because of the shortage of time. Sigmund Freud basically, as I told you, was more towards the sexual conflicts and aggression. But then Erikson was a student and then he became a good close associate and friend of Sigmund Freud. But he decided that the conflicts are there. Yes, there is a conflict. There is a conflict called trust versus mistrust. There is a conflict called autonomy versus shame or doubt. Initiate versus guilt. Industry versus inferiority. Both of them agree with the conflict. But what happens is Erikson says that the child is not alone when he is undergoing this conflict. So he has somebody called a social relationship. There is a social environment which helps the child go through this conflict. So Erikson would call it oral sensory stage rather than just oral stage as explained by Sigmund Freud. Sigmund Freud will call it anal stage and Erikson would call it muscular anal. So don't call the stages based on the conflict. Don't tell stage 1 trust versus mistrust. No. According to Sigmund Freud, it is oral. According to Erikson, it's oral sensory. Anal, muscular anal. Phallic, locomotor genital. So what is the clinical implication of this? You need to identify there is something called mode here in this particular slide. Mode is the most characteristic feature which gets imbibed in that particular age, that particular stage. That is the most characteristic feature which gets imbibed is helping you develop your personality, right? So if there is a problem, if there is a conflict in the first stage, your hope is at stake. If there is a problem in the second stage, your will power is at question. In third stage, there is no purpose to life. Fourth stage, there is no competence. Fifth stage, it is called fidelity. Fidelity means loyalty. So how do we relate this to child psychology? Understand that the social relationship, it's the mother here, it's the parents here, it's the family. Then it becomes his friends, the school, right? And adolescent, it becomes the peers, right? So each person is going to influence the personality. There is a conflict. So let us say oral stage. The child is born with a trust versus mistrust. A dentist is a total stranger, right? Once a dentist is a total stranger, the child will not have trust on. The mother is the social environment. It's important that the mother is staying inside the dental office and you're not sending the mother outside, because the child should not have fear of stranger, which is you, the dentist. That is the clinical. Let us say second stage, anal stage. Anal stage, muscular anal. The child develops willpower to do something. The parents are supposed to teach the child to have willpower, right? So what happens when the child crosses the second year of life? They start to initiate small things. Once the child has a hope in his life and there is a willpower to do something, he might want to explore. The third stage, the phallic versus locomotor genital, exploration is the key word. The child wants to initiate something. He tries to do something. If the mother or the parent or the family, which is the social environment, is not going to allow the child to initiate something and explore, the child is going to have a guilt. Then the child will not be able to explore new things. In the dental office, a 3 to 5 year old child likes to explore. So show him around the dental clinic. Give him a suction and say this is how it works. So use euphemisms, use second languages to explain to the child who's willing to explore. Allow him to handle a mouth mirror. Right. So this is something which you can do because the child has a purpose. He wants to explore. That is the clinical implication of this theory. The fourth stage, the child is ready to compete. There is competence here because he's at school. The friends are there. They all try to compete. There are a lot of competitions in school, right? A small initiative which came up, right, will grow into a full-blown industry if the social environment allows him to do. What if his teacher says it's a stupid question, it's a dumb question, don't ask such kind of question? The child will feel, okay, some of his friends are very good, they're superior to him. He has an inferiority complex. That's why it is called industry versus inferiority. So look at this, when the child basically has a trust, he has hope. When there is an autonomy, there is a willpower. Once the trust and autonomy is there, the hope and willpower is there, the child has a specific purpose and then he initiates something. This initiative, if it's promoted, it grows into a full-fledged industry. The child is able to identify himself as a person, right? So that is what happens, the positive side. The negative side is mistrust, shame or doubt, guilt, inferiority, identity diffusion or role confusion. Children like to have an identity for themselves, right? So what happens is they will not go and discuss everything with their friends, with everybody in the classroom. They will specifically have a group of few friends who are actually their peers, who are their best friends whom they can want to share. So if there is a lot of peer influence, there's a lot of peer pressure. And during this adolescent phase, I told you that could be passive resistance. And then you have to agree that the children might not talk to you the way how the younger children are talking to you. Till about 10 years, children are ready to talk to you, talk about their school, talk about all what is happening at home in their neighborhood. But adolescent children like to be quiet, especially adolescent girls would not want to talk the way how the boys will do. So this is something which I want you to understand. There is a specific mode which gets imbibed in the personality. And this personality is something which we have to relate with their age and based on the stage in which they are. Then you have to apply. So I'm going to give a revision or recap of what I've spoken. Look at this first stage. It's only about feeding. The second stage, this is oral stage, so feeding. Second stage, toilet training because it's anal stage. Third stage is about exploration. Children need to begin asserting control and power over the environment. Till then, it was about them. Eating food, toilet training. That's all. Food and then toilet. That's all they did. Now they are trying to explore external environment. So they need exploration which is happening. School gives them a lot of competence. Look at this need to cope up with new social and academic demands, right? So there is a chance for them to have a sense of competence which happens, and that's important. The fifth event, which is the social relation. This is where trust, friendship, fear, that happens. So basically, first stage, remember separation anxiety. Second stage, remember the children are getting their autonomy, willpower, they become self-directed. Third stage, they start to explore. Fourth stage, what are they? They're ready for multiple things because they're ready to compete. Fifth stage, they're peer pressure. So take home for Sigmund Freud and Erikson is in this particular slide. So this is the only slide which I want you to take for clinical implications of Sigmund Freud and Erikson. Okay, concept of fixation. I also want to add that thumb sucking, if you go to habits chapter, if you look at thumb sucking, they will say classical Freudian theory. Children who are thumb sucking after 5 years, 6 years, right? They are fixed to that oral state. So don't say classical Freudian theory in thumb sucking. Take concept of fixation. The child should have crossed from oral to anal to phallic to latency, but they are still stuck to putting their thumb into the mouth because they're fixed to oral state. The concept of fixation is what I want you to write as a clinical implication in thumb sucking habit, and don't write it as just classical Freudian theory, right? So the difference between classical sexual theory and psychosocial theory. Sigmund Freud believed that children were slaves. They were very, very passive, right? And they succumbed to the biological pressures. And this pressure was predominantly, as I told you, sexual or aggressive conflicts which happened at young age or childhood. Social theory, the psychosocial theory put forward, the Erikson says that children are very active. They can adapt. So what I want you to understand is children who are on the negative side need not necessarily continue on the negative side for lifetime. If their social environment is good, great parents, if they have good friends, if they have great teachers, children who feel negative also can get changed. So they can adapt to the external environment. They are very active. They are not passive slaves. So the common thing between two theories is there is a conflict. But psychosexual theory, they will say they are like slaves. They are very passive. Focuses on the sexual urge. But here the focus is more on the social influence. They are very active and adaptive explorers. That's what is the basic difference. So obviously, one is based on the conflict between the id and the superego, which is a psychosexual theory. That's the third point. The behavior is stemmed out of the conflict between id and superego because they're pulling the ego on both sides. The ego is the reality based, which is the social environment. Obviously, children are not facing the conflicts alone. The conflict is faced by the child in the presence of the social environment. The social environment plays a major role. And so ego plays the major role in psychosocial theory. I think this is what we can give in a rapid revision. But I hope if you have any questions, I can take it up at the end, or you can email me whenever if you have any question, right? So if I finish the first two theories quickly, I think I'm on time. So learning theories. So this is behavior. This is development of behavior or learning. So what are we going to talk about? What is learning? Learning is a relatively permanent change. If you did something wrong and somebody came and scolded you, will you change for lifetime? It is not possible. You will change in the immediate behavior. Like after about a couple of 3 months, 5 months, 6 months, maybe you will not do the same mistake as a PG student. Then again, you will go back to your mischief. This is because learning is not a lifetime change. Learning is a relatively permanent change in the immediate behavior. And why did this happen? Because you had some experience. That's what the definition says. And this learning is divided into two: associative learning, non-associative. Associative learning means they associate two stimuli. One stimuli, two stimuli, you associate these two stimuli, and then you learn something. This is associative learning. Classical conditioning and operant conditioning is associative learning. Non-associative learning is basically habituation and sensitization, right? So give me a second. So and for the same stimulus, if the response keeps reducing and reducing and reducing, say for example, your teacher scolds you, and then you get used to same stimulus, but the response keeps reducing, so you habituate. The same stimulus, you get scared more and more in this department because they might fail you with the final exam. Same stimulus, but the response keeps increasing, you're being sensitized. So when I say sensitization, one is the fear or insight related to that is keeping on increasing sensitization. So what do we need to do? In behavior management, clinical application, we desensitize the patient. A patient or a child who is sensitized to handies. First thing for children, you identify the fear. Identifying the fear becomes the important factor. The minute you have identified the fear, you have to feel whether they're sensitized to it. If they are really sensitized to it, the only thing you can do is desensitize. That's it. So it looks simple, it's theoretical basis, but I want you to apply this in your practice as well. Coming back to associative learning, I am including 3: classical conditioning, operant conditioning, and you can see now the social learning theory or observational learning theory by Albert Bandura. So look at classical conditioning theory. I'm not going into concept. I'm only going to tell you clinical implication. White coat is a neutral stimulus. Means it does. A child seeing a white coat would not cry. But seeing a white coat with injection, white coat injection, two stimuli getting associated. That's why classical conditioning is called as associative learning. right? I told you it's called associative learning because two stimuli, white coat injection, white coat injection, white coat injection. White coat, which was a neutral stimulus, has become a conditioned stimulus because children are not looking at the white coat, they're looking at the associated unconditioned stimulus. You don't need to condition a child to cry for an injection. He's been having vaccinations for quite some time. He's a white coat guys are going to give me an injection, the child's crying. So what is actually happening? The child is acquiring information acquisition. The child is generalizing that, oh, okay, all doctors are going to be like this, all white coat guys. Whether he's a bus conductor, whether he's a policeman, if he's going to wear white coat guy is going to give me an injection. It's a straightforward generalization. You as a pediatric dentist, the clinical implication is you have to discriminate yourself. You will say, okay, the child, you went to a dentist, you went to another dentist, you said all dentists are the same, you generalized it, but I'm going to try and show that I'm going to be different from the rest of the crowd. That happens by discrimination. What do we do? Clinical implication, first visit, don't do major stuff. Try to establish communication with you. Try to talk to the child. Talking, communication is the key for behavior management. Right? So you establish communication. Allow the child to explore the learning. Give him a crayon or a paper and a pencil or something to draw. You can give him a chalk and a board. So allow the child to feel that I am going to give you a different experience, different from whatever the previous dentists have given. Discriminate yourself. The minute you discriminate, the child feels, okay, what I acquired is gone. That is extinction. Acquisition, acquiring information, generalization all is the same. You discriminate yourself. What is acquired is totally done, which is extinction. But always remember there's no universal formula in treating children. It is important that you understand that every time a child walks into a dental clinic, you always treat him like as if he's walking. He's walking. Remember that every time you start with the same process. If you don't start with the same process, they can always go back to his acquired earlier, and that is called, oh, that guy is a doctor. The acquisition comes back again, and this is called as recovery. So be careful to discriminate, be careful to cause extinction, be careful not to allow spontaneous recovery. Is right. Operant conditioning. That experiment by B.F. Skinner, right? The rat knew what to do. The rat has a pleasant stimulus and an unpleasant stimulus. Pleasant stimulus is anything which we need. So pleasant stimulus should be given. That's why. An unpleasant stimulus should be removed, right? So don't make mistakes. See postgraduates across the country making a mistake on negative reinforcement. Negative reinforcement is removing unpleasant stimulus. Unpleasant stimulus is withdrawn. Negative reinforcement means you are escaping what you don't want. So once you give what you want, that is positive reinforcement. What I don't want, I am removing, which is negative reinforcement, right? Time out. What is omission or time out? Time out for a pleasant stimulus. If the mother is the pleasant stimulus, sending the mother outside becomes a timeout. The positive reinforcement example will be all your social reinforcer, your material reinforcer, your activity reinforcers, 3 types of reinforcers. Negative reinforcement, you can think about your kind of distractions, your content, where whenever the child is raising the hand and say, I want to stop for a break, right? It is an earned rest. We say contingent escape or earned rest. The child says, I don't like dentistry, I don't want to have a drill. But you allow the child to say, okay, I will drill for 10 seconds, count to 10 and raise your hand. That is negative reinforcement. That is contingent escape. Time out for the mother because we know that the child is actually can be cooperative, but he is not being cooperative. Send the mother outside, time out, which is S1 is withdrawn. Pleasant stimulus is sent outside. S2, voice control, hand over mouth exercise. Unpleasant things which are being given to the child so that his behavior will be better. That is called as punishment. So that's why we call this as instrumental conditioning. We call this as instrumental conditioning because who decides? In classical conditioning, the dog cannot go and take his food. Only after they will give the food or they won't give the food. But here in rat's experiment with B.F. Skinner, the rat can press the lever and take the food. The rat can decide whether he can take the food or he will get an electric shock. Similar in instrumental conditioning or operant conditioning in pediatric state, the child is given an opportunity and a choice to decide whether he take positive reinforcement, negative reinforcement. You tell the child if you're not going to cooperate, I'm throwing your mother outside. You tell the child if you are not going to keep quiet and listen to my instructions, I'm going to put my hand back again. Voice control, hand over mouth exercise. The child is given a choice. The child operates on the environment, operant conditioning. The child is instrumental for what is happening, instrumental conditioning, right? Okay. Now, classical conditioning, operant conditioning is based out of somebody, right? Okay. Classical conditioning. I'm just waiting outside my HOD's room. Abhiji is standing with a leave letter, right? He is going inside and you wait outside and see through the glass and you find that the teacher is blasting at him or very angry face is seen. You're not able to hear anything. You just are also waiting outside with a leave letter. Will you go inside? You know that this is not the right time to go inside. You observed and learned. You didn't experience it directly. That is exactly what observation learning is. Observation learning is you should have the cognition. That's why the social learning theory is now called as social cognitive learning theory. Without cognition, social learning cannot happen, right? So whom do I see? I should see somebody in my own social experience, right? I should be able to relate to that particular person. That's why it's called social learning theory. Vicarious learning because it is learning out of somebody's experience. I'm learning out of somebody's experience and that's called vicarious learning theory, right? So the models which we see, observational learning theory, we know it's modeling, right? We know it's modeling is based on observational learning theory. What are the 4 steps like acquisition, generalization, discrimination, extinction, spontaneous recovery in classical conditioning? Here there are 4 processes. Attention, retention, reproduction, motivation. You attentively see something. Then you retain it on your head. For this is why I say this cognition is necessary. What you see, you have to retain. And then when somebody keeps motivating you to do, you should be able to reproduce it, right? That is why we call this as imitation. You see something, you're able to learn it by observation, and then you try to imitate. For this, you need a little bit of cognition. So I like this slide, favorite in child psychology for me, right? Look at this. Stimulus response is Pavlov. Stimulus response consequence. The consequence decides your behavior again, right? How you behave in that particular visit, you get a reward, you get a pat on the shoulder, you get a pencil, you get a certificate. The child comes back and behaves properly again. So stimulus response consequence. Stimulus response consequence in another person which you observed and learned. This is Albert Bandura's observational theory, right? So if there is a question on learning theories and implication, it's a very, very straightforward, easy answer. I've just put it on a particular slide. Okay, I only have another 10 minutes and I have to rush in this. So classical conditioning, operant conditioning, what are the behavior management techniques? Who proposed it? What are the other names and what are the behavior management techniques? So we quickly see cognitive learning theory. Jean Piaget believed that there has to be an equilibrium, right? He gave the same set of questions to different children, 3-year-olds, 5-year-olds, 6-year-olds, 7-year-olds. Then he found that people answered the questions differently. He didn't say older age group had better mark. He didn't do that. He didn't say younger age group got lesser. What he did was older age group understood the question right because they were equilibrated. That's why he felt there is a new information assimilation. Once that information is added to your brain, you accommodate it well. This assimilation and accommodation keeps happening, right? And then the child is said to be cognitively productive, means there is a cognitive equilibrium. Once this cognitive equilibrium happens, in each cognitive equilibrium happens. So children at 2 years cannot understand what happens at 4 years. Children at 4 years cannot understand what happens at 7 years. That's what Jean Piaget believed. So he called this as an invariant developmental sequence, meaning that at each stage of life, children learn certain things because of their cognitive development, right? So let us say pre-verbal sensory motor period, less than 2 years of age. Pre-verbal sensory motor. Forget about animism, object permanence and all that. I'm not talking about it right now. I'm only giving you that presentation for this. But pre-verbal sensory motor period means the child cannot talk. So how are you going to establish communication? Communication will happen in a non-verbal way. There is a rule called 738-55 rule, which is by Albert Mehrabian. Only 7% of your communication is through words. 55% is non-verbal communication. So it is important that as a pediatric dentist, you pick up non-verbal communication, especially from pre-verbal sensory motor children. And these children have short memory. They're very sensitive to stimuli. The first slide I told you they can have fear of sudden noise, movement and all that. This is all that pre-verbal sensory motor period. So relate that pre-verbal sensory motor period with the first slide I showed, compare it with oral sensory stage, oral stage of Sigmund Freud, then you get a number of what you should do for clinical implication. So I told you on the parent or caregiver's lab, parent support is important. Maybe Telshodo will work. modeling won't work. Children will not be able to understand. They will not be able to see a 3-year-old, 4-year-old and say, okay, I will also behave like this. It will not work. So that's a clinical implication. Second stage is the pre-operational period, where we see a lot of features like pretend play, symbolic play. This Surf Excel ad is an example of animism and imminent justice. Centration, the child is fixed to something. The child is fixed to a concept. A tall glass beaker has more water for a pre-operational child. A child in formal operation will say, you poured it together at the same time, so both has to be the same. But a child in pre-operational period will not be able to clearly differentiate. It will say tall glass beaker has more water. 3-mountain experiment was used to find out something called E center. The child will always pick up the mountain which is close to it. So these are concepts which I cannot explain, but these concepts are used to treat a pre-operational child. Look at this. Overemphasis was on visual aspects rather than intellectual understanding. 2 to 7-year-olds means they are less than first standard, second standard. So what they see becomes extremely important. What you display in a dental clinic, what should come behind in the dental operatory, what your assistant should pass behind you is very important. They cannot pass an injection right in front of their eyes. Visual aspects are important, right? So tell, show, do will work, modeling will work, rewards will work. They're in school. Stickers, right? The best student for the day, best classmate, like if you tell them that the best patient and all that, liking the gifts you give, they will be very, very cooperative. So this is important for you in a pre-operation period. Concrete operations, again, we have concept of conservation, reversibility. In concrete operations, the child will tell you, pour it in back into that beaker A or beaker B, which has the same size, both has the same water, because they have a concept of reversibility. How do we apply this here? Actually, these children are after second standard, 7+. 7 to 11 years, what happens is, they have competence. According to Sigmund Freud and Erickson, they are in competence stage, latency stage. There is competition in school. They are ready to quickly learn addition, subtraction, everything, right? So they will say tooth plus chocolate is equal to decay. So decay tooth minus chocolate is equal to healthy teeth. So you can give them answer because they can understand addition, subtraction. Involving these children in a cognitively productive way is extremely important. 7 to 11-year-old children, it is not that we can treat them well. Their cognition accepts dental treatment because they are competent. You can tell the child, let me see who's holding it better. The assistant will be ready for a competition. This is the clinical implication which I. Common operation period, again, adolescent egocentrism, imaginary audience, personal to L-kind, but I told you have to relate this formal operation period to adolescent phase of Sigmund Freud and Erickson. Passive resistance. They might not fit into everybody's common universal formula rules. They might not establish eye contact. But if you try to tell them that this will be good for your aesthetics, your peers might like it, they might consider it. So establishing communication becomes extremely important. I'm going to give a small gist of it. In concrete operation, the word itself says concrete, 7 to 11 years, second standard to 5th standard. If the teacher says stand in a line, they will stand in a line. Pin drop silence, pin drop silence. That means they have a rule book. They go by the rule book. So if you set a clear set of rules, these children, you will see that they will come and complain. Expansion appliance, my mother did not do this today. They forgot, right? Because they go by the rules. So clinical implication is go by the rule book. Modeling will work. Parental presence, rewards will definitely help. Informal operations, you can reason with them because they are adolescents, right? Their views may not be the same as those of the dentist. So if you tell them that this is good for you, they might not take it. If it's good for them, they will accept it. So you have to reason and set what goals are going to be common for both of us. So some amount of taking responsibility has to happen between both of us, between the patient and the dentist in treating adolescent children. So this is the take home which I want to give you. So these are some of the references which I really want you to look at the books. 2 wonderful articles which is given. And before I conclude, I just want to brush through quickly in the last 3 minutes I have. We started with the Stone and Church classification, age of the child, because I want you to understand the age of the child is going to decide specific features. The Sigmund Freud stages, it is the mode which we are going to see, right? And you have to compare, if you make a flow chart between Sigmund Freud, Erickson, and cognitive theory by Jean Piaget, then you can actually equate and see what is the emotional feature here? What is the social thing which I can take? What is the cognitive thing I can take? how can I apply this into the learning of this particular child? Then it becomes a very child's play. I think it's very easy to understand child psychology. Lot of English words, but don't look at it as an English word. Try to apply it and see how do we look at the age of the patient, compare it with the stages of children, and then see whether they are going to be frank and right. Then you know whether they're going to be cooperative or uncooperative. Based on these features, try to see what kind of answer you can place it there. So if I stop just 2 minutes before my time is over. Thanks again for the patient hearing. Thanks to the organizers, Madhu sir and specific, for giving me this opportunity again to be a part of Pedia RaRe. Thank you so much. I'm ready to take some questions. Thank you.
Thank you so much, Dr. Sharath, Ashwin, and Sonali for the lovely presentation on this wonderful topic. I think I think students have to ask the questions now, or we can, the organizers, Dr. Virendra, Dr. Madhu.
Sir, there are hardly any questions on the psychology part.
Dr. Baliga,
Yes,
Dr. Baliga, I think we should take up the questions.
So one
because
question I'd
students have
like to
plenty
ask.
of questions, and maybe in the chat box, the speakers can type it online. They
Yeah,
can
that
type
should be
the
better.
answers to the questions. That will be better. Because if we are not able to answer their questions, then maybe they will not be able to write us the mail, and then they are hesitant in writing the mails to the speakers, right? So it's better that the speaker should give the answers either online, or they should type the answers in the chat box. That will be better.
I think chat box would be a good idea, sir.
Yeah,
I think that should be
because
fine.
everyone can read the answers then.
Yeah, absolutely.
And
I think
whatever the
Sharath,
references are there, even that those can be mentioned in the Q&A sections, so that everything is taken care well in time.
Yeah, perfect. So we can be on time, and I think the speakers can just answer on the chat box, and you can give your numbers if at all further doubts are there, so that they can clarify anything.
I think there were 2 questions, and I have replied to that in the chat box itself.
Oh, very nice.
Reference they've asked, I'll share the references also.
Yeah, perfect. I think that way time will be maintained, Dr. Virendra.
So,
Dr. Madhu?
Yes, sir. Thank you, Dr. Sharath Asokan, sir, for that beautiful presentation. Now we'd like to conclude the first session. I request Mr. Dev to project the certificate of appreciation to Dr. Sharath Asokan, sir. Okay, thank you. I thank the moderators for the session, Dr. Baby John and Dr. Sudhindra Baliga. I request Mr. Dev to project the certificates of appreciation to both Dr. Baby John and Dr. Sudhindra Baliga. Mr. Dev.
Dev is angry with us, huh?
Thank you, Dr. Baby John.
Thank you so much.
Mr. Dev, other certificate to Dr. Sudhindra Baliga.
Thank you, organizers. Lovely. Thank you so much.
I thank all the speakers, the moderators. We'll be starting the next session sharp at 1 o'clock. So please log in. So that will end the first session. Thank you.
I would like to just mention here that the student must have received a link from the Zoom, and the same link will work for all the days. They don't need to change the link. The same link will work for all the days. And if at all anyone has not received any Zoom link till now, you can tell your friends to get in touch with me, and I will share the email again to all of you. And this will be live on Facebook also, but unfortunately, I'm not able to make it live on ISPPD group because of some technical issue, but that is available online on my personal Facebook page. And I have shared the link for that online thing on this chat box also. But once we are live again, maybe the link will change and I'll share it in the chat box. And if at all any technical issue is there, just feel free to get in touch by calling or by emailing, and we will share the link again to all of you. Thank you so much.
Thank you, sir.
ಮುಗಿತಾ ಸೆಷನ್? ಕ್ವಶನ್ ಆನ್ಸರ್ ಇಲ್ಲ. ಓಕೆ. ಇಲ್ಲ ಕ್ವಶನ್ಸ್ ಏನಿಲ್ಲ. ಶರತ್ ಇದೆ. ಹೇ ಶರತ್. ಹಲೋ ಶರತ್. You muted yourself.
I'm here, sir. I think only both of us are there. Sure, sir.
Sharath.
Sir. I think some questions, and I've replied back to some of them, but I'm not able
Sharath, you are not the only one. There are 476 participants along with many others.
Okay, sir.
Because
okay,
this is a webinar. You are
the
not
panelists are seen. Okay,
others. This
yes,
is not
sir.
a Zoom meeting platform.
Yes, sir. Yes. I understood that, sir.
Yeah.
Okay, sir.
Any questions, Srinivasan? Okay.
So, Dr. Madhu, there were few technical problems. People were not hearing the voice clearly.
Yes, sir,
Maybe it was because of the internet issue at their end.
Yes,
and
sir.
many of them have not received the link. Many were not able to join. But in the end, I think we are able to rectify everything.
Sir, actually, very few people, one or two only complained of the audio disturbances and all.
No, but that's okay, because that may be because of the technical, internet issue at their end. The internet connection may be low.
One or two complained, it's okay, sir. Definitely.
Yeah, but that's okay. But otherwise, I think it went well, and I could make it live on my Facebook also.
Yes, sir. Great,
and I'll try to rectify the issue why it is not coming to the ISBPD group. Maybe because I'm not able to log into that platform. But it's okay. Even if it is available on Facebook, maybe into mine one, that's okay. People who wants to, they can watch it.
Okay.
We will join maybe 10 minutes before 1 o'clock.
Yes, sir.
Right?
So,
yeah,
yes,
yeah.
Sir. 12:45 only we'll log in, sir.
Yeah, yeah. And Dave, if you're there, just make sure that you download the video, the recording on your computer, and then delete from the system so that we have more free space in the iCloud for further recordings. Right. And we will try to upload the videos of all the speakers, all the lectures on ISPPD website. Just make sure, Dave, that you create one link for uploading all these videos on the ISPPD for website for the benefit of the students. So then they can watch it anytime later. Yes. Right? Yeah.
This is what some people were asking.
No worry. No, we'll do it, Dr. Madhu. We'll definitely upload all these videos on the ISPPD website, and they will do it at the earliest possible time, right? Yes. And then we have made hard copy of the certificates. Yes. And I think by tomorrow it should be with me. Already we got a courier from Delhi. Okay. It should be with me, and within 3 or 4 days I'll start sending the certificates to the courier, by courier to all the speakers and the moderators. And you just make sure that you give me the correct addresses for all. Right?
Yes, I'll take all the postal addresses and send it.
Yeah. And they will be sending e-certificate attendance to all the participants into the membership portal. He will do it. Yeah. Okay. Yeah. Okay.
We'll
Dave, any questions? Any query? Everything clear?
Any query, Srinivasan?
Yes, sir. Clear, sir. Clear. I'll send the certificates through the member login portal itself. They can download.
Yeah.
All
so
the
certificate of attendance you should prepare, right? For all the participants who have registered through ISPPD email, website. And hard copy I will be sending to all the speakers and the moderator. You don't need to worry about that. And just start working on the uploading of all these videos on the ISPPD website, but not now, after conclusion of this program.
Okay, I think all the videos that should be in iCloud, I think so. Zoom cloud.
From the iCloud, you download the video and keep the iCloud free for further recording.
Yeah, okay.
right? In the
I
lunchtime,
can check it out once whether this video is downloaded or not. Actually, that
it will be
it's in
it will
recording
be
process.
downloaded. It will be downloaded. You can easily do it.
Yeah. Okay.
Right.
Sure,
Right?
I'll do that.
Yeah.
Yeah, sir.
Okay.
Okay, sir.
Okay. Bye-bye.
Bye, Sharath.
Sir, thank you, sir. Bye-bye, sir.
Okay,
Bye.
sir.
I'm trying
See you
to
in the
find
afternoon session, sir.
Sir?
Thank you, sir.
Yes, sir. Thank you, sir.
Baliga is there? Dr. Baliga? No, he's not there.
Okay, sir.
Okay, right. Okay.
Bye, sir. Thank you, sir.
See you, Sharath. Bye. End session. Okay.